my pleasure to introduce Dr. Powell, who is going to be speaking to us regarding her research here. She's got 1 more year left or 2 years left, excuse me, in training. And so when she's done, we got to try and convince her to stay somewhere in the state of Michigan because she's great. So welcome, Dr. Powell. I'll
Awesome.
yield control to you.
Thank you. Do I have control? I don't know if I have control yet. Okay.
There you go.
Perfect. So hi again, my name is Chloé Powell, and as mentioned, I'm a vascular surgery resident at the University of Michigan. And so I'll be presenting direct and indirect effects of race and socioeconomic deprivation on outcomes following lower extremity bypass.
Click somewhere, anywhere on your screen, Dr. Powell, and then hit the down arrow.
All right. Here we go. Thank you. Disclosures are detailed here. Okay. So racial and socioeconomic disparities in outcomes for PAD and following revascularization have been well documented. However, most research uses administrative data to identify contributing factors, including patient comorbidities and utilization and access to high quality care. However, limited studies have evaluated the influence of disease severity on these outcomes. And thus, we performed a retrospective analysis using the BNC2 quality registry to assess the direct and indirect effects of race and socioeconomic status on outcomes following lower extremity bypass, as mediated through a measure of advanced disease, so CLTI, using mediation analysis. And we captured all patients that had open lower extremity bypass from 2012 to 2021. And as mentioned, our exposures were race and socioeconomic status measured by the Social Deprivation Index, for which the fifth trying to go back a slide. Okay. For which the fifth quintile represents the most deprived. Our outcomes included 30-day major adverse cardiac events and 30-day and 1-year surgical site infection, amputation, and bypass patency. So this conceptual model really highlights the potential pathway through which we're thinking about these disparities. And so the proposed sort of total effect of race and socioeconomic disadvantage on postoperative outcomes is through mediated indirect effects, so path through A and B. And then the direct effects of race and socioeconomic disadvantage is sort of pathway C. And so the use of my term effect, we're not really implying there's a biological effect of the exposure on the outcome, but really tries to understand sort of the causal mechanisms that are underlying the inequities in outcomes. And as mentioned before, while there's a plethora of evidence demonstrating disparities in outcomes, the use of mediation analysis in the study is unique in that it explores the influence of disease severity as a possible intermediate factor to help explain the relationship between race and socioeconomic deprivation on adverse outcomes following lower extremity bypass. So a little over 7,000 patients underwent lower extremity bypass. The mean age was 67 years. We limited the analysis to Black and white patients, giving the small number of other racial groups. And just under 20% of patients were Black, 30% were female, and about a third were in the fifth quintile for SDI or lived in the most socioeconomically deprived areas. And then patients had sort of the standard comorbidities for those with PADs, including hypertension, high cholesterol, diabetes, COPD, history of TIA or stroke, prior MI, and a history of smoking. So I know this is quite a large table, but in unadjusted outcomes, Black patients were significantly at higher rates of bypass occlusion, amputation, and SSI at 30 days and 1 year. And similarly, patients in the 5th quintile for SDI had significantly higher rates of all adverse outcomes at 30 days and 1 year, except major adverse cardiac events compared with those who were in a less socioeconomic disadvantaged category. And then those patients who were admitted with CLTI were significantly more likely to experience all adverse outcomes at 30 days and 1 year. So just to sort of highlight some key terminology, because I think this will be sort of critical in trying to understand this table. The conditional direct effect, or CDE, incorporates information from the exposure and treatment interaction. And so CDE quantifies the exposure's effect if all patients were to present without advanced disease. So this is where the CDE M equals 0 in this red box here. And then the other CDE M equals 1 quantifies the exposure's effect if all patients were to present with an advanced disease. And then NDE is a broader summary of the exposure's overall effect that does not involve the mediator. So in this case, advanced disease is our mediator. And finally, natural indirect effect represents the exposure's effect attributed to disease severity mechanism. And so the descriptor natural is used for natural indirect effect and natural direct effect to highlight the fact that their sum equals the total effect of the exposure, which in turn makes it possible for us to do the mediation calculation. And so based on the conditional direct effect, in the absence of CLTI, Black patients had increased odds of 1 year amputation. In the presence of CLTI, there were significant conditional direct effects by race, where Black patients had increased odds of bypass graft occlusion at 30 days and 1 year. And then Black patients also had decreased odds of major adverse cardiac events at 1 year. There were significant direct effects between race and bypass patency, where Black patients had higher odds of an included lower extremity bypass graft at 30 days and 1 year postoperatively. And accordingly to the mediation analysis, there were significant natural indirect effects, where Black patients were more likely to present with CLTI and thus had increased odds of 30-day amputation, 1 year amputation, and 1 year SSI. And so the percentage of the total effect of race that can be contributed to admissions with more advanced disease was just under 57% for 30-day amputation, about 64% for 1 year amputation, and about 5% for 1 year SSI. And then based on the conditional direct effect, in the absence of CLTI, patients in the 5th quintile for SDI had increased odds of 30-day bypass occlusion and 1 year amputation. And then in the presence of CLTI, patients in the 5th quintile for SDI had increased odds of SSI at 30 days and 1 year. And they also had increased odds of 30-day and 1 year bypass occlusion. There were significant direct effects where patients with the greatest socioeconomic deprivation were at increased odds of bypass graft occlusion at 30 days. And there were increased odds of SSI and bypass graft occlusion at 1 year. There were significant natural direct effects where patients were more likely to present with CLTI and thus had increased odds of 30-day amputation and 30-day SSI, as well as 1 year amputation and 1 year SSI. And so the total, the percentage of the total SDI effect that was mediated through CLTI was about 59% for 30-day amputation, 36% for 1 year amputation, and about 13% for 1-year SSI. And so this study has several limitations, one being sort of generalizability may be limited since, we used a registry specific to Michigan. The registry sort of didn't allow us to look at peripheral endovascular interventions. And so considering that the chronicity of PAD and the likelihood that patients with PAD have undergone multiple lower extremity procedures, the inability to capture PVIs kind of hinders our ability to investigate whether PVI utilization prior to bypass impacts outcomes. And then we cannot evaluate outcomes beyond the 1-year time frame. And so sort of the lack of long-term follow-up potentially has implications for the capture of complications associated with PAD-related interventions, which can sometimes take years to manifest. And then SDI as a measure captures a disadvantage at the neighborhood zip code level, but zip code information provides less geospatial granularity as compared with census tract or census block data. And then probably most importantly, though our study focused on race and socioeconomic status as separate exposure variables, we recognize that they're actually quite intersectional and in very complex ways, and unfortunately tend to be synergistic. And so these negative consequences could be further exacerbated in that way. So in summary, Black patients and socioeconomically disadvantaged patients were more likely to present with CLTI, which is associated with poor outcomes following lower extremity bypass. I think what is also interesting was that in the absence of CLTI, Black patients also had increased odds of amputation, which kind of raises the question of whether or not intervention outcomes for claudication and whether or not we as interventionalists are causing more harm in that setting. And then sort of more globally, disparities in outcome, ultimately are sort of downstream manifestations of structural inequities. And so I think there's a lot of opportunities to mitigate these inequities through policy and potentially clinically oriented interventions. I'd like to thank sort of all my co-authors, especially Jeremy, who ran the analysis. And thanks, I can take any questions.